So, hello everyone. We will start pediatric and plastic eye files, and we need all of you to participate because it's very important to understand what is important in pediatric and what is important in plastic questions. And we involved past year exam questions in order to facilitate the high relevant and high yielding exam questions. Okay, please raise your hand to start participation with me. Okay, Dr. Ahmed Ali, Dr. Brianna, Musab, Mina, Isra, Nasiba, Brianda.
Hello.
Hello, Brianda. Yeah.
Okay. A 45-year-old policeman presents to his GP with a firm, symmetrically raised and sharply delineated black patch over the volar aspect of his right distal forearm. Further questioning reveals that the lesion occasionally itches and bleeds. I think it's a... I cannot see the video. Can you see it?
So you see here sharply delineated black patch over the volar aspect of the right distal forearm and occasionally itchy and bleedy. So what is the answer?
It's a squamous cell carcinoma.
The squamous cell carcinoma is a fleshy mass rather than being a black patch.
Okay.
So black patch or brownish black patch is going more with melanoma.
Okay.
So which type of melanoma do you?
Okay, I wasn't sure, but I'm reading here nodular melanoma.
Okay, so again, nodular melanoma in the peripheries, and it's of worse prognosis, and it is easily bleed, and it is itchy. Okay, and symmetrical as well. You can't see the video. Anyone can't see the video as well? I don't see, the video is on in front of you, so you can open the video as you see the screen of the Zoom. Me too. Go on, Nasiba, for the next one, Nasiba.
An 85-year-old man presents to his GP with an irregularly shaped brown patch over his left cheek. Examination reveals thickening and development of a discrete cutaneous nodules. Okay. I think it's lentigo malignant melanoma.
So over the cheek, over the back, irregular shaped brown patches. It is called lentigo malignant freckles or Hutchinson's melanotic freckle. Occur in the elderly, sun-exposed sites, and it is very good prognosis, least malignant variety of melanoma, and it can be over the cheek, as you see here, and it is associated with
yes, with discrete cutaneous nodule.
But if I told you amelanotic melanoma and then I could describe it as non-pigmented. So this one is lentigo malignant freckles, and it is of good prognosis. Acral of the sole and the palm is bad prognosis. Nodular of bad prognosis. Lentigo malignant freckles of fair prognosis, and superficial spreading melanoma is the most common and of not that bad prognosis. Next one.
A 72-year-old farmer presents to his GP with a 2-month history of a rapidly growing solitary, freshly and elevated noodle over his left cheek. Examination reveals a firm, non-pigmented noodle with a hyperkeratotic core. So
This is MRCS question. Last one.
Yeah.
Keratoacanthoma is very, very important.
number
Keratoacanthoma is rapidly growing epidermal tumor resembling squamous cell carcinoma, both clinically and histologically. Okay? On
Okay.
the sun-exposed area as a squamous cell carcinoma till now. It is single fleshy elevated nodular lesion with central hyperkeratotic core. But the most significant histological feature is that the rapid growth rate.
Yeah.
And it is of low, very low malignant potential, but mimicking the squamous cell carcinoma. Don't forget this description for keratoacanthoma. This is one of the MRCS exam questions. So just quick orientation about melanoma. Melanoma is malignant tumor of the melanin producing cells called melanocytes. And 95% confined to the skin, while the rest can occur in the extracutaneous sites, like the eye, GIT, even the central nervous system and genitourinary system and lymph nodes as well. Okay. There is radial growth phase, radial growth like this, and vertical growth. This is what's called the radial growth, so to grow like this, but the vertical growth to grow deeper. When I tell you vertical growth, so this means invasion. So vertical growth is associated with poorer prognosis. There are 5 main types: superficial spreading, and this is the most common type, nodular, lentigo-maligna, and acral, and amelanotic, acolorful melanoma. The best prognostic indicator is stage 1. This is non-metastatic malignant melanoma, and you don't forget this one, Breslow thickness. This is essential measure to predict the prognosis and predict the 5-year survival rate. So it is depth of invasion. It is millimeters, measuring the overlying granular layer depth. Okay, so it is like if I told you there is invasion deeply, radial growth less than 1.5 millimeter, this is a good prognostic sign. If I told you there is more than 3.5 millimeter, this is poor prognosis, deeper invasion. Okay, and according to this Breslow thickness, which is essential prognostic feature, it will be defined the excision margin. Less than 5 millimeter in situ Breslow thickness, then it is at least 5 millimeter, half centimeter excision margin. If I told you 1 to 2 millimeter Breslow thickness, then the excision margin will be 1 to 2 centimeter. If I told you 2 to 4 millimeter, it is 2 to 3 centimeter excision margin. More than 4 millimeter, it is 3 centimeter excision margin. Again, don't forget, you will not be asked about this because there is a lot of tables. Okay? So you will be very clear about if it is more than 4 millimeter, then he will give you a value that will be clearly 2 or 3 centimeter. If I give you the initial excision margin, it will be half centimeter, which is 5 millimeter. Okay, so I will show you the up-to-date 2020 table, which is more reasonable because this is published 2010. So I'm showing you the up-to-date 2020 schedule on the group rather than this one, Breslow thickness and versus excision margin. Okay, so this is a nodular melanoma. This is very bad prognosis, and it is the most rapidly growing aggressive subtype because there is no radial growth, which is good growth, not bad growth. Okay, and it's seen in the trunk limbs of the patients and of little melanin. Lentigo-malignant freckles or Hutchinson's melanotic freckle. This is occur in the elderly, sun-exposed size, and least malignant variety. Can be multiple over the back or single over the cheek. Keratoacanthoma, this is a different type. This is of low malignant potential tumor, histologically and clinically, with very rapid growth epidermal tumor resembling squamous cell carcinoma, but of very low malignant potential, and this is the difference. Very important to understand a question from endocrine, but very important to revise the tumor markers. So thank you, Nasiba, and this is for Shamaila to answer this question.
Hello, Assalamu
alaikum.
A 54-year-old woman present to her general practitioner with the 4-month history of progressively worsening of flushing and diarrhea. A thorough physical examination revealed a prominent thyroid nodule at the base of her neck, and it is associated with the cervical lymphadenopathy. And this is a calcitonin, probably the medullary thyroid cancer.
Excellent. So medullary thyroid cancer, don't forget the association, the main syndrome for sporadic medullary thyroid carcinoma. So medullary thyroid carcinoma is, what is the origin of medullary thyroid carcinoma? Do you know?
Parafollicular C cells of the thyroid.
And what is the origin of parafollicular C cells, the embryological origin?
Sorry, I don't recall.
Fourth branchial arch with the ultimobranchial body.
Ultimobranchial body.
Yeah, which is a different embryological origin, not like the thyroid. What is the embryology of the thyroid gland then?
Thyroid gland arises from the base of the tongue.
Foramen cecum.
Foramen cecum at the base of the tongue.
At the base of the tongue, between the anterior 2/3, the V-shaped border between the anterior 2/3 and posterior 1/3, and it will arise thyroglossal duct. And this thyroglossal duct will extend from the base of the tongue until reaching the midline of the neck. And please know that this thyroglossal duct will be degraded and vanish after birth to be of no significant embryological remnant. But if I told you there is remnant or not closed, not obliterated at some point, it will be forming what is called thyroglossal duct cyst. And yes, the thyroglossal duct cyst operation, what is called?
Cyst trunk operation.
Excellent, cyst trunk operation. And because of this thyroglossal duct cyst, while descending from the tongue, the midline of the neck, its way to the midline of the neck, it is hooking around the body of hyoid. That's why in the cyst trunk operation, it is important to remove part of the hyoid as part of the surgery to ensure no recurrence of thyroglossal duct cyst, because part of the duct is hooking around the body of hyoid bone. Min syndrome sporadic means randomly, or Min syndrome is occurring as part of Min syndrome. Do you know what is the features of Min type 1?
In medullary carcinoma occurs in men type 2A and 2B, the Werner syndrome.
What is Min 1? Min 1.
In men 1, there is pituitary tumors with, there is the, I think, insulinomas and pancreatic cell tumors.
So tell
And
yourself Min 1 is 3 Ps.
3 PCS and hyperplasia, parathyroid hyperplasia.
Parathyroid pituitary.
Parathyroid pituitary and pancreatic.
Okay, that's fine. The component of Min 2B is?
A component of MAN 2B is medullary carcinoma and morphinoid body feature, pheochromocytoma and morphinoid body feature.
So medullary thyroid carcinoma, pheochromocytoma, morphinoid body habitus, and mandibular osteomas.
Mandibular osteomas, and I think soft tissues tumor, tumors was also.
Yes. What is the type of Min 2A?
Man 2A, in Man 2A there is
Thyroid,
parathyroid adenoma and medullary carcinoma and pheochromocytoma, I guess.
Thank you. So the follow-up of this medullary thyroid carcinoma with calcitonin. Next one.
A 40-year-old woman presents to her general practitioner with 6-month history of intermittent colicky, central abdominal pain, and diarrhea. The episodes are associated with flushing, palpitation, and occasional dyspnea. This is the carcinoid tumor and the chromogranin A.
Chromogranin A. So what is, can you tell me what is the whole study for carcinoid syndrome?
Whole study? Sorry?
Yes, it's a study.
Origin?
What is the most common location for carcinoid tumor?
Most common location of the carcinoid tumor is appendix.
Small intestine.
And small intestine. Sorry.
Not appendix. Small intestine. Because the appendix is part of the colon, okay? But
okay.
The most common location for carcinoid is the small intestine.
Okay.
What is the studies for carcinoid tumor or carcinoid syndrome? And what is the difference between carcinoid tumor and carcinoid syndrome?
The carcinoid syndrome, when the features of flushing and all these palpitation and diarrhea develop, that occurs when the tumor has metastasized to the liver. This is when it's
at the beginning. Excellent. So the tumor is secreting 5-hydroxytryptamine like serotonin, which is serotonin actually.
Yes.
And this serotonin is already metabolized by the liver.
By liver.
It is carcinoid tumor only, right? Because the liver is going and clearing this rubbish. So the patient is fine, syndromic, not symptomatic. So there is only tumor. But when the factory itself, the cleaning factory itself got injured and liver metastasis happen, then the lesion itself now causing harm to the liver, which will not be able to metabolize the serotonin. So there will be what?
There will be carcinoid syndrome.
The 5-hydroxytryptamine will be excessively not metabolized and will be manifested by palpitation, diarrhea, dyspnea. Okay, very nice, very nice. What is excellent? So diarrhea, flushing, abdominal cramps, asthma, wheezing, pellagra skin lesion. CT is the indication to localize the primary tumor and assess the extent of the tumor spread and metastasis. Occultide scan, 111 scan, this is localize primary carcinoid tumor and recurrence. The studies you told us urinary.
Urinary collection of 5-hydroxy indole acetic acid.
The best measurement of urinary excretion of 5-hydroxy acetic acid. Okay?
Yes. Yeah.
Because 5-hydroxytryptamine is degraded into 5-hydroxy acetic acid excreted in the urine. What is the viboma features? What is the viboma features? Do you know what is the viboma features?
Vipoma.
Yes, viboma.
Features of vipoma. Vasoactive
Yes,
intestinal peptide.
Yes. Wadha syndrome is Wadha syndrome. Again,
Watery.
WDHA. Watery diarrhea, hypokalemia, or hyperemia. Watery diarrhea,
Yes.
hypokalemia.
Hypokalemia.
Excellent.
Sorry.
Excellent. Okay. Next one.
65-year-old African man presents with a 12-month history of worsening of back pain and generalized muscle weakness and anorexia. Examination reveals limited lumbar spine movement, but no evidence of neurological deficit. His laboratory investigations reveal the hemoglobin level of 7.7 gram per dl and hematocrit of 23 and platelets of 10 lakh, I guess. Creatinine of 380 picomole and urea of 26 millimole per liter, and corrected calcium is 3.2. The plain radiograph of his spine demonstrates the multiple radiolucent foci within the lumbar vertebral bodies. This is a beta 2 microglobulin. I think this is a multiple myeloma. Platelets are raised, I think. And spine, multiple radiolucent foci within the lumbar vertebral bodies. Beta 2 microglobulin.
Beta 2 microglobulins or M spike chain in protein electrophoresis. This is multiple myeloma. The Krabs features of multiple myeloma. Do you know Krabs features of multiple myeloma?
No.
Anyone here attended the question posting session and knows what is the Krabs features of multiple myeloma? Krabs.
No.
Calcium, hypercalcemia, excellent. R, renal affection problem, so renal insufficiency. A, anemia.
CRA, yes. Renal failure.
Still B.
Bone
lytic lesion, not bone pain, no. Bone lytic lesion. Skull worm-eaten appearance. Okay, so crabs. Really, it is crabs. Really. Okay, if you will attend the question posting session, I'm sure you will get above 90%. Okay?
Inshallah.
Inshallah, you will get this, but if you will follow. Because, but, okay. So crabs, multiple myeloma. Do you know what is multiple myeloma even?
It is the tumor of the plasma cells.
Yes, it is a plasma cell tumor. And it is the most common, if you read iSense Orthopedics, there is talk about what is the most common tumor of the bone marrow. The most common primary bone tumor is multiple myeloma.
Yes.
Bone lytic lesions. Okay. Next one. And M beta 2 microglobulins and M chain spikes. In the protein electrophoresis, there is a shape drawn to a normal distribution of your proteins. Okay, so the M light chain will be spiked. This means that this is higher secreted by the plasma cell because it is a tumorous, it is cancerous, it is neoplastic. So it will secrete a lot of proteins. Thank you so much. This is very important exam question for pediatrics. So I will open the mic for Mustafa. Thank you, Shumalia. You are excellent. Continue your study, and I'm sure you will do. Mustafa, Ahmed Ali, Nasiba. Thank you, inshallah.
Assalamu alaikum.
Go on.
Yeah. A 5-year-old baby girl with cystic fibrosis is brought to the emergency department with gross abdominal distension and bilious vomiting. She is not taking regular feeds and appears dehydrated. Plain abdominal radiography reveals distended coils of bowel, but no overt fluid levels. Meconium ileus.
Meconium ileus. What is Meconium ileus? Do you know?
Yeah, Meconium ileus. What happened in the bowel? There will be. It's characterized by abdominal distension and bilious vomiting. There will be abnormal meconium due to there will be thick secretion of meconium.
Excellent. I agree.
Because
so it is neonatal intestinal obstruction due to thickened meconium. Excellent. It is occurring in 20% in patients with what? Cystic fibrosis.
Cystic fibrosis.
And what is cystic fibrosis?
Cystic fibrosis.
It is
the sodium channel.
Okay. Listen to me. Cystic fibrosis transmembrane conductance regulator, CFTR gene mutation. This gene is responsible to degrade the mucus in your body. If this CFTR gene mutated, then your body mucus will be viscid. Okay?
Yeah.
So the associated features is cystic fibrosis. What is cystic fibrosis? There will be cysts and fibrosis in the pancreas, in the lung, in whatever. Okay?
Yeah.
Symptoms is failure to pass meconium, abdominal distension, palpable bowel loops, and this is the X-ray, abdo X-ray, and contrast enema performed to confirm and treat meconium ileus when there is no evidence of perforation. Do you know what is a sweat test?
It is usually done in cystic fibrosis to see the levels of sodium and chloride.
I told you what is a sweat test. test on the question posting session. So simply, it is called the sweat chloride test. So it measures chloride in the sweating. That's it. For screening of cystic fibrosis, because there will be defect of chloride channels.
Yes.
So that the concentration of chloride in your sweat will be higher with cystic fibrosis. That's it. Is it clear?
Yes, sir.
Okay, so the question is meconium ileus associated with cystic fibrosis. Next one.
A 31-week-old baby boy born prematurely in the pediatric ward is asked to be reviewed with a distant and tense abdomen. The baby is passing blood and mucus per rectum. She is also manifesting signs of sepsis. Plain abdominal radiography revealed distant loops of bowel and gas bubble within the bowel wall. The answer is necrotizing enterocolitis.
What is necrotizing enterocolitis?
That happens usually in premature babies, like when prolonged use of antibiotic for more than 5 days, and there will be the colon.
Okay, we are studying together, by the way, so no need for feeling late or feeling. So simply, it is what is called intestinal necrosis, right, in the neonate. So it is neonatal intestinal necrosis. More common in males, and most common risk factor is infant born below 3-5 weeks. Okay.
Yeah.
So it will be associated with neonatal sepsis, and don't forget the word prematurity, feeding intolerance, vomiting. Okay, so dyspnea, lethargy, feeding intolerance, abdominal distension, blood in the stool because of the necrosis. Okay, radiography will show the diagnosis of suspected enterocolitis. There will be what is the hallmark of the disease in the abdo X-ray?
Gas bubbles.
Pneumatosis intestinalis. Pneumatosis intestinalis. Air in the X-ray because of the severe sepsis and distension. Okay. Pneumatosis intestinalis. And also, don't forget the blood diarrhea. What is the treatment option? Just gut rest. Rest the gut. How to rest the gut? IV fluids, discontinue no enteral feeding, and start TBN. IV broad spectrum antibiotics because of the necrosis. And also, don't forget abdominal surgery. This is the absolute indication, which is intestinal perforation. So you will do exploratory laparotomy and bowel resection, especially in bowel birth. Is it clear? Is it clear?
Yes.
Okay. Necrotizing enterocolitis, done. Next one.
A 3-day-old baby boy is brought to the emergency department with mild abdominal distension and failure to pass meconium after birth. The child is crying constantly. Barium enema reveals the distending colon to have a narrow segment associated with a dilated proximal colon. My answer is Hirschsprung disease.
What is Hirschsprung disease?
Hirschsprung disease usually occurs due to absence of the aganglionic in
Ganglionic
the
megacolon.
aganglionic megacolon.
So it is aganglionic megacolon, part of your colon or rectum without ganglion cells, so no contraction. So this area will be spastic, aganglionic segment, right? And your bowel contents will be dislodged and accumulated in the above part. So you have stenotic aganglionic segment below. Above it, there is ganglionic normal segment but dilated. This is Hirschsprung disease. Is it clear? Do you know, you have an example looks like Hirschsprung disease in the esophagus?
Ecclesia cardia?
What is the problem of the ecclesia?
There is lots of
low sphincter dilatation. Do you know what is Chagas disease?
Chagas. I can't remember.
The esophagus as well. Chagas disease. Anyone here knows what is Chagas disease? It is Trypanosoma cruzi parasitic infestation, and according to the location of the this Trypanosoma cruzi in the heart can cause cardiomyopathy, in the esophagus can cause megaesophagus, in the colon can cause megacolon. Why? Because it simply hunt the ganglion. This is the Chagas disease. Okay. Is it good revision or no?
Really good.
Really good, but not reassuring. Kids that are not that excellent in pediatrics and stuff like that, right?
Yes.
Okay. But I promise you, if you will revise continuously, you will catch more than anyone. Okay,
Inshallah.
so it is Hirschsprung disease is congenital megacolon, and example is a newborn infant has not passed meconium in 2 days with distended abdomen, and digital rectal exam revealed gas and the stool expelled after you put your finger. And absence of gas in the rectum on abdomen X-ray is a characteristic feature. Congenital, we said function and some obstruction due to absence of ganglion cells. Orbach or Meissner's plexus and lack of nerve cells and failure of neural crest cells migration. This came in MCQ before, by the way. So failure of neural crest cells migration. 99% of Hirschsprung disease in the rectum, and it could be associated with RET gene and affecting boys more than girls, and risk in, by the way, the risk increase with the Chagas disease, the risk increase with Down syndrome, and MEN2 syndrome associated. And you said that failure to pass meconium in the first 48 hours of life, large bowel obstruction, chronic constipation, and no gas in the rectum, no stool in the rectal part, and extremely tight anal sphincter, and your finger can pass a stool after you put it due to release of the obstruction. Imaging, abdo X-ray, distended bowel loops, loss of air in the rectum. So again, in quick, in the intussusception, you can see the treatment can be non-surgical via pneumatic decompression enema via fluoroscopy. It is now preferred over hydrostatic contrast-based techniques. Okay, and surgical reduction only indicated when barium enema does not relieve the obstruction. Okay, so don't forget the intussusception, age, it is 3 months to 3 years. Don't forget the classical triad, colicky abdominal pain. Salam alaikum. Colicky abdominal pain, emesis. Okay, so classical triad of red currant jelly, telescoping sun ultrasound, or do not sign, and red currant jelly, and the baby will bring his knee above his chest for squatting to relieve the manifestations. Thank you, Riham. I will open the mic for you again to continue this one.
Yeah, I think there's a question here in the chat. The Isra, she asked about if there's risk of perforation, how to manage intercession, and what to determine the risk of perforation. So can I ask a moment? Can I answer it briefly? I think Isra, it depends on the duration of the interception. Anyhow, if the patient is not toxic or shows signs of toxicity, we go with ultrasound with enema at first, and then it depends on ultrasound results. So you can manage it surgically, or it's okay with enema alone. So it depends more or less to the moment.
You mean
to the duration.
Mainly most of the cases managed conservatively, yes?
Yeah. But when the patient is toxic, so it's perforated or peritonitis or something like that. So it depends on the general states of the baby, on the general states of the abdomen, and how much has the symptoms on the clinical evaluation of me.
Yes, of course. We do the workup completely, okay? Like you will check whether this baby is perforated or no. There is, like, you will do lactate, CRP, white cell count, abdo X-ray, and then you will see the general status of the patient. Lactate is normal, TLC and CRP is normal. Then you will decide to go with ultrasound, abdominal radiograph, and then you will see if the CRP is high, lactate is high, then your option is surgical, definitely. Because you will not try any instrumentation for fear of already perforated viscous, of course. We in MRCS not give the MDT plan. We just give superficial global knowledge, not the best. It's not for surgeons, it's for knowledge. And this is the difference. Like, you will tell me how you will manage this patient. I don't know. What I know is the treatment options. What I know is the differential diagnosis. At registrar level or SHO level and MRCS level, it's not my level to tell the diagnosis. To tell the actual management plan A, B, C, D, E. Okay, but just a global knowledge, but I agree with you.
So a 6-week-old child is brought to ER by his mother as she has been concerned about severe forcible vomiting shortly after feeding. He is reported to be constantly hungry and there's no history of diarrhea. On examination, the child looks dehydrated and malnourished. Gastric peristalsis is visible, so I'm going with Pyloxenosis, hypertrophic pyloxenosis.
Das ist meine. Das ist deine. Das ist meine. Das ist meine. Das ist deine.
Yes.
Pyloxenosis, I said it. Do you hear me?
So non-bilious vomiting, infantile pyloric stenosis. Next one.
A newborn has failed to pass meconium in the first 48 hours and is reluctant to feed. On examination, the abdomen is distended. Then abdomen radiography showed distended lobes of bowel with absence of air in the rectum. So I will go with Hirschsprung disease. Or a moment.
We described what's Hirschsprung disease, right?
Yeah, moment. Yeah, the Hirschsprung disease. Several episodes of villous vomiting from few hours since birth. On examination, the baby has scaphoid abdomen, plain abdominal ventrology, gastric bubble, proximal to an air-filled first part of the first part of duodenum. So I will go with duodenal atresia.
Duodenal atresia, double bubble sign.
Yeah.
Right. Okay. Down duodenal atresia with Down syndrome. Thank you so much. Thank you so much, Riham. And Riham, I appreciate your participation despite. Until you open the mics, I will open only the mics for people raising hand. Nasiba. Nasiba, can you open the mic?
Yeah.
Yes, go on.
A 62-year-old man presents with a flat sloping edge ulcer over the left medial malleus of malleolus. Okay. It's venous ulcer.
Venous
Hello?
ulcer.
Yeah,
Next
can you hear?
one.
Yeah, a tan 66-year-old man presents with an ulcerated lesion on the nose with a rolled edge. It's basal cell carcinoma. Yes, hello.
Yes, with you. Next one.
60-year-old man complains of a bleeding ulcer on the upper region of the left cheek. It has an inverted edge and there are some palpable cervical lymph nodes. Okay, so it's a bleeding ulcer on the upper region of the left cheek. Okay, it should be squamous cell carcinoma because of the cervical lymph nodes. Up marginally, yeah. See.
Squamous cell carcinoma. By the way, these are about 5 exam questions.
Yeah. A 71-year-old man presents with an exquisitely painful bulged out ulcer on the tip of the right big toe. On examination, the surrounding area is cold. Okay, so it's ischemic ulcer. After so, no, it's too painful, so it should be neuropathic ulcer. Yes, this is a.
Ischemic ulcer. Punched out, arterial امبارح. Yesterday
yeah.
you punched out painful, punched out
Yeah.
painful. Neuropathic is not painful.
Yes, yes.
Okay.
Neuropathic like the one in diabetes mellitus, yeah? A 58-year-old diabetic presents with a painless, punched out ulcer on the sole of the right foot. The surrounding area has reduced pain sensation. So this one is neuropathic ulcer.
Excellent. 5 exam questions. High yielding 5 exam questions. Excellent. Thank you. Thank you, Nasiba. Shumaila again.
Yes. Hello.
Yes.
There's no question appeared here.
Yes, go on.
77-year-old patient presents with 1.5 centimeter raised lesion above the right eyebrow. On examination, the lesion is pearly in appearance with rolled edges and telangiectasias on its surface. This is the basal cell carcinoma. Pearly lesion and rolled edges, basal cell carcinoma.
Excellent to know that this is a basal cell carcinoma. Next.
60-year-old man presents with 2.5 centimeter rapidly growing lesion sited on the right side of the nose. On examination, it has everted edges with prominent keratinization. It can be keratoacanthoma. I'm confused between. This is keratoacanthoma. Rapidly growing because it is rapidly growing.
But with raised everted edges and the right side of the nose, there is no hyperkeratotic core. There is a prominent keratization as well, but I will show you the difference between keratoacanthoma online, like you see here, kerato, now keratoacanthoma. This is the shape of kerato. I will give you the
confusing. This is confusing between squamous and keratoacanthoma.
No, I will show you. It is not raised everted. See, look at the group. This is
yes.
Keratoacanthoma. Look at the group. This is no edges, just a hemispherical one with hyperkeratotic core, which is the whitish pattern in the middle. Not fleshy, not edges. This is keratoacanthoma.
Yes.
I'll show you another picture. But if you carcinoma skin, find it raised everted edges. Everted edges is
raised keratoc.
Yes. So the everted edges is going more like this. This is the squamous cell carcinoma. I showed to the group as well. Okay. So there is the everted edges where is going more with the squamous cell carcinoma. Next.
45-year-old woman presents with dark 8 mm lesion on the lateral aspect of his right lower leg. It occasionally bleed on contact. This is a melanoma. 1 minute. Dark 8 mm lesion on lateral aspect of occasionally. This is the melanoma, but it's not malignant melanoma. Nodular type.
Last one.
Malignant. Question has not appeared yet.
Next one.
35-year-old woman complains of browny red pedunculated lesion situated along her appendectomy scar. Browny red pedunculated lesion along her browny red. The keloid. This is keloid.
What is the difference between keloid and the hypertrophic scar?
The hypertrophic scar grows beyond the margins of the incision or goes beyond the scar. Hypertrophic is. I'm a bit confused in between both of these, but this is the difference. I think beyond keloid goes beyond the scar, not hypertrophic scar. Keloid goes beyond the scar.
Vice versa. So hypertrophic scar does not extend beyond the initial site of the injury, but keloid typically project beyond the original wall margin. This is the difference. And this is very important one. This is next one is inevitable exam questions.
Can I start? 20.
No, I will give it to another one.
Okay.
With you, but let me see other people. Sana, Salwa, Rehan. Anyone can raise a hand?